Over to you, Doctor.
So good morning and welcome to part 2 of this very interesting discussion that we had yesterday. Today we've lined up a little less common problems, but important nevertheless, because proper management can make a huge difference between these children seeing or not. Today's galaxy of panelists include Professor Arif Khan. Thank you very much, sir, for joining us. He needs no introduction. He's an ocular geneticist par excellence, and any conference or webinar on ocular genetics has him giving his comments and expertise. And we have Dr. Anil Mandal, of course, the guru of pediatric glaucoma in India, and joining him is Dr. George Putharan, who we all know as a very prominent pediatric glaucoma person in Aravind. And moderating today's session will be Dr. Shanta, who's the head of glaucoma at Shankar Netralaya. So I hand it over to you, ma'am, to carry it forward.
We will start off with the first talk to be given by Dr. Vinay Gupta on aniridia, and that will be followed by questions for about 10 minutes. So Dr. Vinay, if you could start.
Thanks, ma'am. So I'm going to present a classic case of aniridia. It's a short presentation, and then I'm going to throw in some questions to the panelists, and then I will give my point of view and our experience in dealing with these children with aniridic glaucoma. So this was a case of a 7-year-old boy, and the parents have said that he lost one eye to trauma. I mean, that's what they ascribed the right eye, which was now thicycle. So the only seeing eye that he presented to us had aniridic glaucoma and nystagmus, and he had presented to us with a 40 millimeters of mercury intraocular pressure, which was measured with a tono pen. His visual acuity was only 6/60 in that eye. Neither of the parents were affected. So its other examination, which was positive, was there was a corneal pannus, which was superior. There was an advanced cupping in that eye. The cornea was thick. Otherwise, his systemic examination was more or less normal. So we need to manage this case, and the classic challenges that exist in the management of aniridic glaucoma are, which I think the panelists would like to help us answer, is how do we measure intraocular pressure in an eye of a child who has nystagmus, firstly. Secondly is a question which is also quite often asked and needs explanation, is that what is the role of corneal thickness in these eyes, especially aniridic eyes which have much thicker corneas. And in aniridia, what would be the surgery of choice? I mean, would you want to do a trabeculectomy with mitomycin, or would you consider a glaucoma drainage device, especially given a setting where the child, that's the only eye of the child? And what if the surgery fails? I mean, there is a very high chance of failure. What is the next step? What is the role of cyclophotocoagulation in these eyes? And then, of course, I think Dr. Arif would be the best person to tell us regarding the genetic counseling in children who have aniridia. So with this, I think I will just give off on the questions to the panelists, and we can have a discussion, and then probably I can show you the next 2 or 3 slides regarding what we do and what our experience has been over the years in managing these kids. Ma'am, you're not audible, Dr. Shanta.
I'm audible now? Yeah, Professor Mandal, could you answer the first question on how you would measure the intraocular pressure? Do you make any corrections for the increased corneal thickness which is found in this population? Just a minute, sir. You have to be unmuted. Can all the panelists be unmuted?
I am doing, yeah, now it's all right. It's showing all right. So, am I audible now?
Yes.
Yes.
Yes. So, measurement of intraocular pressure is an important aspect, and it's very difficult when there is nystagmus, particularly in hereditary patient, when it is usually associated with thicker cornea. And the corneal thickness is significantly higher. That should be considered in the measurement error it induces. If the child is otherwise cooperative, probably applanation tonometry in the outpatient also can be tried. If not, probably Perkins tonometer. If that is also difficult, probably tonopen or eye care tonometer is the choice. And if the child is in the age group that will have to do, anesthesia for measuring intraocular pressure and detailed evaluation, we'll have to do that. And there probably Perkins handheld applanation tonometer is the ideal, according to my choice. That's the situation.
Would you allow the measurement of the central corneal thickness to influence your decision to treat? If the optic disc is
That I think we should consider that, but unlike adult glaucoma, here, there is not much information in the literature how much to deduct, but it should be considered in the discussion discussion with the parents. Suppose the intraocular pressure is 25 millimeter of mercury and the corneal thickness is 800 micron. Probably I'll say it's okay, but other parameters should be looked into: the corneal diameter, the optic disc cupping, all these things. So decision has to be made considering all the features in the evaluation, and then the final decision whether we should treat or we should observe.
I think
Dr.
that
Khan,
answers.
any comment? Yeah.
I think that answers Dr. Vinay's question. So perhaps we can go to the surgical question next. We can have a kind of a debate. Perhaps Dr. Sirisha could talk about the results of trabeclectomy, and Dr. George could give us his input on whether drainage devices would be better. So Sirisha, what do you think? Trabeclectomy with mitomycin C or GDTs?
Yeah.
For this particular
So
case.
I think aniridia, when we are talking about, recently we have an article of ours in the review in ophthalmology glaucoma where we have looked at aniridia in children younger than 3 years who need surgical management versus those who are older. So I guess there is a cohort of children who present at very early at birth. These people have a reasonable success rates because primarily I think they have an angle dysgenesis where conventional trabeculotomy and trabeculectomy is our choice, and that seems to work well. And we don't use mitomycin in these children at the first go. Having said that, older children who present to us with enlarged corneal diameters, sometimes they also have the subluxated lenses with typically superior subluxation of the lens and things like that. Their prognosis is not so good, and it's very, very difficult. In my experience, trabeculectomy with mitomycin C is a choice that we do. Because they have limbal stem cell deficiency, we generally don't touch the conjunctiva at the limbus. So limbal-based conjunctival flap with mitomycin is what we use, but these children have a very high tendency to develop localized cystic bleps. Very huge amount of fibrosis is something these eyes encounter, and failures are not uncommon at all in that age group. And we would, if things don't work well, or if one eye has had a problem, then we go in for a primary tube itself.
So less than 3 years, conventional trabeculotomy, and more than that, perhaps a primary trabeculectomy with antimetabolites. So Dr. George, would you differ, or would it depend on the age of the patient? This particular child is 7 years old and is monocular. So any difference in your approach?
Probably our initial surgery of choice for this patient would be a glaucoma drainage device. Just to add on to what Srisha said, in any patient child less than 3 years, we would perform a trabeculotomy alone and not a combined trabeculectomy and trabeculotomy. Again, it's to do with surgeons' preferences and what works well in their hands. And coming to glaucoma drainage devices, apart from the limbal stem cell deficiency, what Srisha was mentioning, many of these patients will require further intraocular surgeries and like cataract surgery. And in such a scenario, probably a tube has its own advantages over trap. But in this particular patient, I totally agree, very challenging, but you need to take all possible precautions. My choice would be to go in with a non-valve implant, taking all possible precautions to avoid ocular hypotony. The advantages of some of the advantages of a non-valve implant over a valve implant in a pediatric age group is one thing, the surface area is much larger, predisposing to much larger surface area of filtration of aqueous permeability, much lower profile blephs, and also once you tuck these plates, wings of the barbell plate of the RD plate underneath the muscles, there's very little chance of anterior migration of the plate. Again, there are opinions. Professor Paul Palmberg was advocating keeping the tube obliquely over the lens sonules in patients with aniridia to prevent lenticular damage during tube insertion. But sometimes it's not practical. We have to be very, very careful about start visualizing the tip of the needle as soon as it enters the anterior chamber and then slowly progress forwards to make sure that it is over the anterior lens capsule. But preventing immediate post-op hypotony will be critical for this patient. Having a good scleral tract, embedding the tube in the patient's own sclera so that the tissues, the conjunctiva is not raised up. All these are small practical tips which would prevent aggravation of limbal stem cell deficiency.
Thank you,
So,
Dr. George.
Can I ask one question? Can I ask a question to George? So, George, in these with the limbal stem cell thing, would you prefer limbus based or phonics based for your valves?
Yeah, there are surgeons. There are surgeons who advocate limbal-based conjunctival flaps for patients with aniridia. I know Srisha does all her patients as limbal-based conjunctival flap, but personally, I go in for a phonics-based flap, and I use almost a 5 millimeter 23 gauge needle track guided tube entry, and I don't use a scleral flap or a patch to cover the tube at the limbus. So my conjunctiva is as flat on the limbus as possible.
Okay, one comment is that with surgeries in aniridia, you get increased incidence of fibrosis, the profibrotic syndrome. So I have a question to Dr. Arif. Is there any prognostic factor with genetics in relation to glaucoma? Does the effect of is there any genetic predisposition to increase failure? For example, the profibrotic syndrome, which has been described. Increased fibrosis following both the drainage devices and trabeculectomy.
Yeah, well, first, thank you. It's such a pleasure to be here, part of this panel and this excellent discussion. I want to thank you for allowing me to be part of this discussion. I'll just say just a few very quick things. I completely agree with Dr. Mandel about wanting to know the corneal thickness, but it's very difficult to know what to do with it. It's just part of a cookbook in trying to understand what's going on. There's no formula for these children. For me, I find palpating is helpful, especially if we think the pressure is 40. I think we'd feel a noticeable difference with our fingers. Dr. Sirisha was saying about the lens subluxation. I find that very interesting point, because when we talk about aniridia, we're really talking about many different diseases. And when we're talking about classic aniridia, typically we're thinking about PAX6 mutation, which is where we have the keratopathy, lack of iris, lens opacity, foveal hypoplasia, and typically juvenile onset glaucoma, as this child seems to have. I don't think Vinay, I think this glaucoma was juvenile onset, not congenital. So this presentation is going with PAX6, and so does zonular weakness, and those patients do very poorly with the conventional angle surgery, and the tubes are much more useful in these patients. It's the PAX6 ones also that tend to get this fibrosis syndrome. So, knowing the genetics of it does help us a little bit with the prognosis. Regarding what I would personally do with this patient is I think this patient needs a valve. It seems to me like a phenotype of PAX6 related aniridia. but it's important to realize that not all aniridia and glaucoma is PAX6. There are other causes as well. There's a specific question there. What is the risk of another sibling having the disease? You know, in a situation like this, when you have an anterior segment dysgenesis, many of the anterior segment dysgenesises are dominant. So it's very important to examine the parents for subtle findings. Sometimes you even find that they have undiagnosed glaucoma because there can be a lot of variable expressivity in these phenotypes. If you examine the parents and they were normal, completely normal, most likely you're dealing with a new mutation in this child which would not be inherited to a sibling. However, there's always the chance that the parent has something called a gonadal mosaicism, where there's a mutation just in the gonad. So even though the parent is not affected, it's still possible to transmit it to another child. So we have to be very careful with our language. Just because the parent is not affected and it seems like it's a new mutation, there's always a risk that there's a mutation in the egg or the sperm that's not manifesting in the parent and confers a risk for another child being affected.
Thank you. What about the role of cyclophotocoagulation? I don't think there's a role as a primary procedure, but what do you think are the results with the cyclophotocoagulation at the end of multiple procedures? Dr. Sirisha?
Yeah, so in certain conditions, especially if they have very severe limbal stem cell deficiency and keratopathy, it becomes very difficult, and conjunctiva is also really bad. In those situations, any conjunctival procedure is a little scary to do. So we do limited transscleral cyclophotocoagulation in these children. But then if it reaches a stage like that, to me, the prognosis is not so good. So we haven't analyzed our results, but offhand, what I can remember is that in a situation where they have a really bad disease, where you cannot offer them the other surgical glaucoma procedures, then the prognosis is not very good.
I'd like to throw this question to all the panelists. What about prophylactic goniotomy? Because if you look at the latest literature, it suggests that open-angle glaucoma is as common as, or more common than secondary angle closure glaucoma in iridia. So this premise of doing a prophylactic goniotomy in the present times, does it have any role? Any of you have any ideas?
I know David Walton is in Boston, proponent of this, but personally I find it difficult to do a surgical procedure on a child who doesn't have glaucoma. So for me, I find it difficult.
Yeah, so
closure glaucoma is common.
For me also the same philosophy. That when the child is doing okay, no glaucoma, just to do prophylactic surgery in a child's eye, at least I'll not go in favor of that.
Do you agree that angle closure is more common than open angle glaucoma in iridia? Because we find that open angle glaucoma is quite predominant whenever gonioscopy is possible.
My impression is probably 50-50. Difficult to, we have not looked into that way prospectively, but almost equal amount.
Perhaps Dr. Vinay, you could sum up now with what happened to your patient.
Just a point, if I can add, Dr. Shanta, that of the drugs, because that does not come out here, it was only surgical management that was discussed. Just to benefit the audience who was there, pilocarpine is one drug that is very useful in the medical management of glaucoma in these children.
Yeah. So I just want to sum up by saying that we do a lot of trabeculectomies in these eyes, especially in a one-eyed child. We do not do glaucoma drainage devices, and our preference is to do a conic space with a single punch, use mitomycin, and use slight releasables. So that gives us a reasonably good blend and reasonably good success rate. But if we do have to do a glaucoma drainage device, I would always prefer doing an AGP over a Barwelt, primarily because I'm not very comfortable with sudden low pressures and high pressures in a child who already has very high pressures to start with. So, and then again, of course, the cornea is an important thing that needs to be considered. These kids will have to live a long life, and with the endothelium getting lost with time, will have serious consequences. And as George suggested, an oblique injection always helps, with you remaining as far away from the cornea and the lenses as possible. I'd just like to tell you about some of our experiences with these kids over a period of time, which have been that we have analyzed some of our cases of anaerobic glaucomas. They had almost like an 8 to 9 years follow-up. And while we were looking at these things, we realized that one of the important things was that these children actually had very poor vision. So as they grow up, they have so many other problems. You just can't deal with the glaucoma. They develop cataracts, they develop corneal decompensation, and over a period of time, the long-term prognosis actually is very poor. In fact, almost 80 to 90% of these children only land up with a visual acuity of 6/16. So I think this is another thing that needs to be realistically explained to the parents. Another interesting thing that we found in our study was that a lot of these kids, almost like 1/4 of these children had phthisis bulbi. So for some reason, the more surgeries you do in anaerobic glaucomas, the more likely are they going to land up into severe hypotony and phthisis. And I think that needs to be considered very carefully. Sometimes even minor trauma can have very serious consequences. So when we look at, I think there is a malformation of the ciliary body. Apart from the iris, even the ciliary body primarily is malformed. So anything that we do, we must be very careful of the fact that this eye can go into phthisis bulbi, and therefore restrict our surgery to the minimum. Any comments? I mean, about the fact that you have seen hypotony or atrophic bulbi in these eyes. I mean, I don't know about the rest of the people, but we have a very high incidence of that.
I think
can I comment one point?
Yes,
in the primary surgery, newborn glaucoma with aniridia, one can consider primary trabeculotomy, primary trabeculectomy, or combined trabeculotomy. The surgeon should remember that in advanced cases, the Schlemm's canal may not be formed. There may be agenesis of Schlemm's canal. If somebody plans for only trabeculotomy, ultimately it will probably end in trabeculectomy, because a significant percentage of patients may not be having a good formation or embryologic abnormality related to Schlemm's canal and the outflow drainage, aqueous drainage system.
I agree. I think we run out of time for the first talk, so we'll go on to the second talk and then decide on answering some of the questions at the end if we have time. So I thank the panelists. We'll go on to the second talk now. Dr. Sirisha, can you take up your topic on acute eye drops?
So I need to share screen.
While she is getting things ready, perhaps Dr. Arif Khan could just tell us when we need to screen for Wilms tumor in these children.
Yes, we're worried about Wilms tumor in a newborn who has classic aniridia where there's no family history, because when you have a new case in the family, that probably represents a new deletion. And when it's a new deletion, if it's large enough, it hits not only the PAX6 gene on the short arm of chromosome 11, but can also hit the neighboring gene, WT1. And if the deletion is large enough to hit WT1 as well, that's what gives the predisposition for Wilms tumor. So we're concerned when we have a new child, a newborn in the family with classic aniridia, and there's no family history. Because typically when there's a family history and other family members affected with aniridia, typically that's an intragenic PAX6 mutation. So it would not be affecting the neighboring gene WT1.
So I have not been given access to share my slides yet. Pratibha, can you give me the access?
Yes, ma'am. Just give me one moment.
I'll say one more thing. When a child has congenital glaucoma and no iris, I find it's uncommonly PAX6. That's usually not PAX6 because the PAX6 glaucoma is typically later.
Dr. Shirisha, you are now live.
Yeah. Can you see my slides?
Yes, yes. Slides are visible.
All right. Can I start, Dr. Shanta?
Yes, please.
Okay. So acute eye drops is a condition where there is sudden clouding of the cornea, and that happens because of stromal edema, and that again is a consequence of a tear or a break in the Descemet's membrane. This is not common, but when it happens, it is quite dramatic, and it's sometimes scary, and sometimes you see the parents actually rush in, even if it means it's an emergency in the evening or in the night. So we need to understand what are the conditions that can cause this acute eye drops. And as a pediatric glaucoma specialist, we see it more commonly with children with congenital glaucoma or infantile glaucoma. Most often it is unilateral, but we also see babies who are brought into your clinic maybe 2 days or 3 days after birth. As soon as the child opens the eye, they find that the cornea is very hazy, and the parents or the grandmother or the grandfather brings in the child. So birth injury is something that we need to think about, and I will come to the features that can actually suggest whether it is birth injury or not. Rarely, Axenfeld-Rieger syndrome also has been associated with acute eye drops. And more commonly, we are used to seeing corneal eye drops in conditions with corneal ectasias like keratoconus and keratoglobus, apart from the other degenerations. So this is a child who was brought into the clinic with a whitish discoloration of the left eye. So 2 hours after birth, the baby was noticed to have this kind of haziness, and the child was brought into the clinic. So this is not uncommon, especially when you do not see a megalocornea. When the eye, there can be little congestion, but usually you see this whitish discoloration in the center of the cornea. You see, if I can just go back to this picture, you see it, it's more like a prolate kind of a thing from superior to the inferior area vertically. And sometimes the haziness can also be involving the entire cornea, depends upon how much of Descemet has ruptured. So these are the pictures after the healing. You may have a single vertical line or sometimes 2 vertical scars or habstria that are seen. Typically, this is seen in the left eye. That is because of the left occipito-anterior positioning of the child during pregnancy, during birth. And the vertical striae typically appear because when the forceps is applied. Why does this happen? This happens because when the forceps delivery is going on, suppose the forceps slips and then the inferior orbit of the left eye gets caught and there is a vertical kind of a compression. Any compression, severe compression on the eye can increase the intraocular pressure. That also causes deformation of the cornea, which is more deformed horizontally, because of which when this deformation happens and then when there is a release, suddenly there is a rupture of the Descemet's membrane that can present as this edema or scar. This disappears. Usually mild steroids is something that we give as treatment, but we obviously have to follow up because when there's a lot of corneal haze, you do not see the scar, so you do not understand what is happening. But amblyopia is a serious issue and they need to be tackled. There's just one case report that I came across where there was a patient with Axenfeld-Rieger. This was actually an older gentleman with Axenfeld-Rieger who had presented with acute corneal eye drops, which was treated as a corneal ulcer. So something like a perforated corneal ulcer. But then this can happen because of the extensive thinning in the cornea that can happen in a localized area, more commonly closer to the area of extensive peripheral anterior synechiae that they see. Keratoglobus again is a condition where you have a huge cornea. There's uniform thinning of the cornea. Because of thinning, they can have excess stretching and thinning can cause a split in the Descemet. and it's a brittle cornea syndrome is another name that is given to these patients. The reason why I'm showing keratoconus is not very common in a very young child, but this can happen because at least in India, it's not children more than 5 years. So 5 to 15 years is a typical presentation of children with vernal keratoconjunctivitis. But we also have seen children younger than that because they can have either a VKC or an any other form of a severe allergy that they can be associated with systemically, or they can also present in older individuals. But I want to bring your attention to this clinical picture. You see that the peripheral part of the cornea is relatively clear, and this opacification happens more so slightly eccentrically and may not involve the entire cornea the way you typically see in acute eye drops that presents with congenital glaucoma. Just keep this in your mind. I will come to this a little later. So this is a presentation, a publication from our institute where they have looked at the acute eye drops and how do they treat an acute eye drops associated with keratoconus. Is either it resolves by itself, but if they have a larger Descemet's detachment like this, they use an intracameral gas or intracameral air. And then if the scarring is very severe, depending on how centrally located the cone is, they may think in terms of a keratoplasty. But coming back to the childhood glaucoma, they're typically unilateral. But recently, Sushmita's group has published a paper where they have looked at the contralateral eyes of these children who presented with one eye acute eye drops, have also developed eye drops at some point in time later. So this is something that we need to keep in mind. And if which means to say that if the child develops a eye drops in one eye, they may be at risk of the other eye developing, and especially if we are continuing them on medical treatment, one needs to be very careful and need to discuss this with the parents to maybe try and facilitate the surgery at an earlier date. So enlarged cornea, uniform diffuse haziness of the cornea. It's not localized. Sometimes you can have localized more haziness compared to the periphery. They can have mild congestion because of inflammation. And like I said, usually they have corneal diameter which is beyond 13 millimeters. And definitely if it is 14 millimeters or more, they're likely to have this problem. These are just a few guidelines for megalocornea. B-scan ultrasound is something that we definitely need to know, because if something is sudden, we have to rule out any other pathology in the back of the eye before you take it up for surgery. So just a few points about why it happens. We know that elevated intraocular pressure causes increasing the size of the globe, megalocornea, and also the increase in axial length. There are breaks in Descemet's because Descemet's stretch, but they are not so elastic. Beyond a certain point, if there is stretching, they can break and they can cause a sudden gush of fluid into the stroma, causing corneal edema. In keratoconus, it is different. That's ectasia, not usually associated with rise in pressure. So just to differentiate the two. What another caveat is, in these children, when you take them up for a surgery, examination under anesthesia or for surgery, you need to realize that when you do a tonometry under anesthesia, or even otherwise in the clinic, you may have underestimation of the intraocular pressure because of the stromal edema that they have. So this is something that we need to remember. So IOP of 12 or 10 or 6 does not mean that the child does not have elevated IOP in this eye. You're wrongly underestimating it because of the edema. So this is something that we need to remember. Definitive treatment, of course, is surgical and depends on whatever one's choice is. Of course, the goniotomy is not a choice here. Trabeculotomy or a 360 trabeculotomy or a trabeculotomy with trabeculectomy is the choice. In ectasias, like I said, they typically resolve by themselves or the intracameral gas is given. What happens when you have a Descemet's break? It resolves with a HAB striae. That is something that we need to keep a watch on. So one of the important things is that depending on where the striae is located, it induces very severe astigmatism. That is a point that one has to remember, and they need to be followed up very closely. So initially, you don't see the striae very clearly, like is shown in this picture. This is the same patient's photographs over a period of time. And if you see the last picture, you can see a very well-defined HAB striae that happens because of the laying down of the basement membrane by the adjacent endothelium, and that covers the broken Descemet's, which is rolled up. Okay, this is a series that is published by Dr. Mandal. What I want to draw your attention to is the significant myopic astigmatism seen in close to 3/4 of the patients with acute corneal eye drops. This is something that I was alluding to, where we need to be very careful about rehabilitation of these patients at the earliest. As soon as their cornea clears, one needs to rehabilitate them. So this was a case that I recently saw. A couple of weeks ago, I operated this child, is a 6-year-old who has dermatitis. And she had steroid-induced glaucoma because she had a VKC as well. She was using topical steroids as well as periocular steroids for a very long time, as well as the steroids on the skin. So the mom sent me pictures saying that suddenly her cornea has become cloudy like this, and we do not know, but she's been having high pressures for quite some time now. So she lives in Bombay, and because of this pandemic, they were not able to travel anywhere. So I was not sure, and then we referred the patient there itself in Bombay to a cornea specialist who saw the child and then had an ASOCT done. There was increased corneal thickness, but they were not sure about what this condition was. So luckily, the mother actually had taken photographs of this child on every single day. You can just see the evolution of this edema. So essentially, there is little bit of edema, and as time went by, the corneal edema increased and it became almost a full cornea. So this is something that I wanted to bring your attention to, where I had shown you pictures of keratoconus developing eye drops usually in older children. Younger children, megalocornea developing eye drops is not uncommon. So this child has a VKC, does not have megalocornea, but has high pressures. Possibly this child also has some amount of ectasia which was not noted, and this child developed acute eye drop. So this is something that we need to remember. Otherwise, the cornea specialist actually thought this child had stromal keratitis, and they were thinking in terms of treating her steroids, and they were concerned because the child has steroid-induced glaucoma. So this was the peripheral corneal thickness was so much centrally they could not even record because it was really, really thick. And this was the picture that I was taken on the day that I operated this child a couple of weeks ago. You can see a huge herb striae that is there extending from one edge of the limbus to the other edge. And fortunately, it is off the central axis. So this herb striae had already started developing. The cornea had significantly cleared by the time they could get access to coming to Hyderabad. So this child I had operated, and at the end of the surgery, this was the intraoperative pictures. At the end of the surgery, I had also placed an air bubble in the anterior chamber just to see if there was any amount of the edge of the Descemet's tear, if it is rolling, just to make sure that it gets opposed faster. That apart, I had done a trabeculectomy, limbal-based trabeculectomy with mitomycin C in this child. So to summarize, acute eye drops is a rare presentation. We should identify the cause. Most often, like I mentioned, the cause is the enlarged corneal diameter, but you can have a birth trauma as well as keratoconus presenting as emergencies as well. And the treatment depends upon the cause, and astigmatism and amblyopia treatment is definitely very, very important. Although we clear the cornea, but we need to make sure that this eye doesn't develop deep amblyopia. Thank you.
Thank you, Dr. Sirisha. I would like to invite the panelists to talk about their experience. Have you had similar cases? What were the predisposing factors? How do you differentiate acute eye drops from corneal edema associated with the primary congenital glaucoma?
May I ask a question? That was a great presentation. That last case that you had with the steroid-induced glaucoma, how old was that child? He was 7?
6 years old.
6, and you're saying that he developed a new Habe stria associated with this? That's really unusual. That's very unusual. I'm not saying, I've never seen a Habe stria develop at that age. That's really a remarkable thing. Did the child ever have an eye exam before to document that wasn't there? Yeah?
Yeah. Wow. So Dr. Mandal had seen this child, I think, in early February. And, yes. In Mumbai, there are a couple of other doctors who were following her up. And these, if you see, the contralateral eye of the child is completely all right, and the corneal diameter is only 12 millimeters.
You have to report this case because I've never seen a Habe stria at that age, new developed.
No, when I saw the Dr. Khan, carry on. Dr. Khan,
no,
carry
I
on.
was just going to say that in congenital glaucoma, you know, I've seen acute eye drops a few times, but it's so rare. I don't think I have the experience that you have. and you know, it resolves as you know, with time, with regular glaucoma treatment. But I don't have an extensive experience in it. I've only seen a few cases. It seems like you've seen many cases of this.
Dr.
Yeah,
Khan,
we
could it be
reported
because of underlying keratoconus or something, or former fruste? That because in keratoconus you see acute hydrops in older children. So he was VKC, he had all that, and maybe it was associated with wasn't picked up.
Yeah, maybe
That's
he
what
had some
happened.
thinning. You know, maybe he had some thinning. I don't know. It's just I'm really in shock. You know, of this child getting a new stria just from increased intraocular pressure at age 6. But I'm not saying that's what happened. It's just it's unheard of for me, and it's really fascinating, and it needs to be looked at very carefully.
So she's going to come to see us. It is a girl, and she's going to come to see us a month. That means 2 to 3 weeks from now, when we'll get a topography of both her eyes. So that's what I was mentioning. Possibly she had a former fruste, and she also had raised intraocular pressure. So there were more than one risk factor for possibly for her to develop this problem. That was really scary and very dramatic presentation.
Actually, we've had 2 cases which developed acute hydrops. One was a child I had performed combined trabeculotomy and trabeculotomy on that cleared up completely the first 3 days, and the 4th day developed acute hydrops. We used a handheld OCT during the time of examination to figure out what had happened. And in the area of the HAPS striate, there was a Descemet's detachment. So following an intracameral injection of air, it settled down and the child recovered within 5 days. We had another case also, primary congenital glaucoma, treated, operated on, but presented at the age of 30 with a similar problem, an acute hydrops which developed from the area of the Descemet's detachment. So she had elevated IOP2, so there was a dilemma as to whether to treat the Descemet's detachment first and then go ahead with the glaucoma surgery. So we elected to treat the Descemet's detachment first. Pneumo-desmetopexy was done, and about 3 weeks later, re-trabeculotomy was performed. She did very well. They agreed that it's a very rare problem in congenital glaucoma. I think most of the reports that we have are with keratoconus. And the issues of using, yes, sir.
Santa, carry on.
Please.
Santa, carry on. You are telling something?
No, I think they describe using the long-acting gas. So one of the issues in these eyes is a pupillary block caused by the large gas bubble, and reports of corneal decompensation and lens changes as well. So that's something you have to keep in mind in these already compromised eyes. It's better to use something which is not of long duration. So they've suggested that you use either SF6 or perfluoroethane instead of perfluoropropane. These are some of the suggestions which have been offered in the literature. Yes, you have something to say, Dr. Mandal? We have time.
Yeah, I was telling whatever cases we reported in 23 years from 92 to 90 to 2012, a series of 31 patients of 23 children. All the children were in the age group of infantile within 1 year. I think within 1 year of birth. This is for the first time Sirisha presented the case. I saw the child a few months ago, but I advised surgery. At that time, at least keratoconus on clinical examination, I may have missed. I don't know. Probably that was early stage or former fruste of keratoconus was there. And the hydrops developed when the child was waiting and the parents were deciding in favor of surgery and was buying time to come for surgery. And by the time patient developed acute hydrops. One case I can remember in the Indian Journal of Ophthalmology 1983 from All India Institute reported a case, steroid-induced glaucoma, keratoconus, and presented as acute hydrops in the age group of, I think, 13 or 14-year-old child. The predisposing factor is glaucoma, steroid-induced glaucoma, the development of keratoconus, and rubbing of the eye, the very attitude of the children to to rub the eye or allergic manifestation. All these things contribute. Probably is multifactorial, not just infantile onset glaucoma or juvenile onset glaucoma leading to acute hydrops. To my mind, acute hydrops solely related to developmental glaucoma, most of the patients will behave within a year or so.
So
and examination of the other eye should be very careful, because I remember in my series, one patient developed acute hydrops. We operated on the child. Examination was done from outside also, where the surgeon prescribed anti-glaucoma medication in the so-called normal eye, but corneal diameter was 13. We advise the parents that we are operating on the affected eye, that is manifesting with acute hydrops, but treatment should continued in the other eye. There should not be any problem. In fact, patient may require surgery in the other eye also. To my surprise, it happened after a week of one eye surgery, which manifested with acute hydrops. Other eye on anti-glaucoma medication with normal intraocular pressure developed a similar attack, acute hydrops, and we operated the very next week on that child.
Dr. Mandal,
one question in these, if you have,
recently.
Yes, of sequential, we've also looked at.
Now that the paper is out, it came to me for evaluation. Very nicely written paper, very good observation.
Okay, thank you. Thank you, sir. Thanks for letting it out. And now it's an ophthalmology glaucoma. But sir, we took this on because we also, a couple of years ago, we somehow noticed that the other eye of patients who we thought were well controlled, once they underwent trabeculectomy in the other eye, for some reason or the other, the eye that we thought was normal ended up requiring trabeculectomy. And then we started looking at intraocular pressures in both eyes, and whether or not they were on Diamox, all the pressures in the other eye tended to rise. And we wondered whether that was the same thing happening with children, that once you lower pressure in one eye, maybe there's a consensual rise of pressure in the other. And in a predisposed child with an acute hydrops, the other eye also gives away. That's one thing. So my question to you is, now that we've observed this, is it a good idea to do bilateral surgery if we see glaucoma in the other eye, rather than wait and then, in case it happens, if on table there is glaucoma, is it better to do bilateral surgery then?
I think when acute manifestation is happening in a so-called normal child with megalocornea, where the parents most of the time thinks that the child is having beautiful eye, a large, borderline larger cornea, prominent eye is a manifestation or a sign of beauty, as at least in India, the parents take that way. I say in that difficult situation, probably it's better to do the way I believe. It's better to do the acutely manifested eye surgery, taking care of that, and put anti-glaucoma medication in the other eye with a good discussion that ultimately the other eye will also require surgery, and proper gonioscopic evaluation, gonio anomaly, etc. if it is noted, along with corneal diameter and optic disc evaluation. Ultimately, we'll have to plan for surgery in the other eye, but to convince the parent. It's the question of when acute symptoms has happened in one eye, in a so-called normal child, probably staged operation will be better to take parents into confidence and then go ahead.
One of the questions from the audience is, how long does it take for the cornea to clear? How long would you wait?
In fact, even without surgery, the moment acute hydrops happens, the intraocular pressure goes down, and that really should not be taken as the patient is doing all right, will not do surgery, something like that. That's a wrong thing. There are cases in the report, in the literature, where acute hydrops happened, spontaneous reduction of intraocular pressure happened, and it was not treated. Later on, secondary rise of intraocular pressure and advanced glaucoma that has happened. Ultimately, surgery was required. So it's the question of assessing the children and plan accordingly. Even if pressure is on the borderline or on the lower side, I'll say it's better to go for surgical intervention.
Thank you, sir. I think we just have about 8 minutes left. So shall we start the third talk with Dr. Sushmita, and then we can take questions after that.
Yeah.
Yeah, so Can you give me the share? Pratibha, I need the share access, please. Yeah.
I have
Okay.
sent you the access.
Okay, is it visible?
Not yet.
Can you,
Not yet.
I've not yet. Okay,
Not yet.
I've shared. My panel says showing main screen.
Yes, it's visible.
Yeah, the slides are seen.
They're seen, all right.
It is seen.
Yeah, so I'm trying to go into slideshow. Okay, is it seen now? Yeah. Right, so we'll wind up this with another interesting rare observation, but once we've seen something called a congenital primary aphakia. So this is a type of anterior segment dysgenesis which is characterized by the absence of the lens. There's failure of the lens induction from the surface ectoderm. There's aborted lens development, and histologically there's total aplasia of the anterior segment. And it's thought to be due to homozygous mutations in the FOXE3 gene. So it's rare, it's seen in less than 5 of 10,000 live births, and the associated eye abnormalities noted include microphthalmia, absence of the iris, anterior segment aplasia with or without sclerocornea. So I'll just quickly present our learning experience of this complex entity. So this little baby was really our teacher. This 8-week-old male, he was diagnosed as sclerocornea and anterior segment dysgenesis, and his pressures were very, very high. But this is what it looked like. And even though we couldn't make out much of the anterior segment, we thought, and the optic disc was cupped, so we thought we must reduce his pressure. But after glaucoma surgery, we landed up in phthisis bulbi. Then we realized on going back to the UBM, and actually I confess the report came to me for review, and when I saw the pictures, it struck me that this was what I was dealing with after all. And when I reviewed the UBM, which we'd done, at that time we just said it's an anterior segment disorganized, but I realized on closer view that there's no lens. And once we knew that, we just did a limited transscleral cyclophotocoagulation in the other eye, gave him +10 glasses, and now this little boy is 3 years old and he runs around with his aphakic glasses. So somebody who we thought was blind, this child actually has very, very good ambulatory vision and almost is about to be enrolled in school. Once we recognized that, suddenly we started seeing a lot more. So this boy came in, this 4-year-old, he was born of a consanguineous marriage. And these are the typical features which we now learned to recognize in all these years. They're shiny, large corneas, there's a silvery blue hue, and there are no anterior segment structures which are appreciable. And when we asked the parent, they said the younger sister was similar, and that's why they've come in. And this little 6-month-old little girl was brought in, she was waiting outside, and her eyes looked the same. So when we knew what it was, when we did the UBM in both of them, we realized it was similar. There was a disorganized anterior segment again, no structures visible, a disorganized desmids also, and no lens. So the management of them is a limited transscleral photocoagulation with aphakic glasses. And I want to present Dr. Murli from LBPI's paper, and I pat him on the back for having presented this, that he's done a penetrating keratoplasty in 9 eyes of children with congenital primary aphakia, and all 9 went into phthisis bulbi. And the idea of the paper was to present to the world, do not do incisional surgery in these babies, because the reasons given are a hypoplastic ciliary process and an abnormal vitreous invariably leads to a consequent hypotony and a phthisis bulbi. So after this, we had another 18-month-old boy, and now that we started recognizing them, I'll just show a tiny clip of how he loves his glasses. So we gave him his aphakic glasses. The parents were very happy, and we thought we'd be bad to him, and we just took it off. And he hated us for it. And the father said that the minute he wakes up, the first thing he wants is his glasses. And so we put this on, and he was very angry with me for photographing him. He turned around, and then finally he realized that he had his glasses on, and then he's happy. So just to demonstrate that all these children require is just a very, very limited cyclophotocoagulation to get it down, and you can actually get a smile on their faces because they can see with their glasses. So we then went back in retrospect. We photograph all the children who came in, and I put all of them into a folder, the ones which we had earlier. And the ones that I put into a folder called sclerocornea and anterior segment dysgenesis, when I reviewed all of them, now that I realized what they were, I found 5 more. 2 had microphthalmos in one eye. All patients initially diagnosed as sclerocornea. 2 of them were siblings, and there were history of parent.
There's no audio.
We've lost your audio, Sushmita.
There's no audio.
Impression?
Ma'am, we have lost your.
Until she comes back on, perhaps Dr. Khan could tell us what the genetic association of this condition is. There are a number of reports of complex
So this
situations.
yeah. Can you hear me? Yeah.
Yes.
So this is really such a rare condition, and it's a fascinating condition. You know, the gene FOXE3, which she mentioned, actually you can have recessive or dominant mutations in the gene, and you can get anterior segment dysgenesis phenotypes. And it just depends on how the mutation is in the gene. But typically it's recessive, it's biallelic. And FOXE3 is responsible for formation of the lens. But you know, when the eye forms and the anterior segment forms, normal formation of the eye is dependent on a normal lens. So if the lens doesn't form, the cornea becomes abnormal secondarily, and the vitreous becomes abnormal, and the iris becomes abnormal, because a normal lens is part of the developing cascade. And even if the genetic defect is just in formation of the lens, and there's no lens, even though there's no genetic mutation in the cornea gene or vitreous gene, the fact that the lens is not there, the entire eye is dysplastic. So these eyes do very terribly with surgeries, as was mentioned. And you know, this silver bluish cornea is characteristic. But again, it's a very rare condition, but it's very important to recognize, because you're not doing these patients a favor if you're doing incisional surgery on them. And, you know, unfortunately, I've seen patients who just go and they keep searching until they find somebody who's willing to do the surgeries, willing to do a PKP, and they end up in ptysis.
Is it
So,
visible
you
now?
know, sometimes the most important, you know, difficult decision
Yeah, ma'am. Screen visible.
is not to do surgery. Yeah.
Sushmita, you want to continue?
Yeah. Can I
Yeah,
continue?
please.
So I think we got stuck here. So then our teacher came back, and interestingly, the mother was pregnant, and she came to us with a question of the possibility in the next baby 3 years later. So we sent her this time for a genetic counseling, because now we understood what it was, and of course it was FOXE3 positive. So FOXE3 has a lens specific expression, and I'd like to refer you to this lovely paper which shows that development of the lens is really, really critical to the development of the entire anterior segment. And problems in lens development results in a range of ocular disorders, including even resorbed congenital cataract, infantile glaucoma, microcornea, microphthalmia, even Peters anomaly, and non-specific anterior segment dysgenesis. So we sent her to a prenatal ultrasound diagnostic lab, because we also found a report on ultrasound prenatal diagnosis of congenital primary aphakia. And there they confirmed both lens placodes are seen and a normal looking eye structure. So they've decided to go on with their pregnancy, and we called her back just 2 days ago because I had to give this presentation. She's due to deliver in 2 weeks. So all our fingers are crossed, and we hope the next baby is fine. So the take home points quickly is, first, recognize the condition. It's so characteristic, and I'm really kicking myself for not picking up these babies earlier. no incisional surgery at all. We use IOP reduction by always transillumination and cyclophotocoagulation, and you can see where the ciliary process is. But remember, these ciliary bodies are hypoplastic, so it has to be very, very limited. We don't do more than 3 or at the most 4 quadrants at a time. It's okay to come back. Aphakic glasses is a boon. The children really are happy with them. We need to do, this is one condition where genetic testing for FOXE3 is almost always pathognomonic, and very important to counsel parents for their next baby. But then remember that prenatal diagnosis in the first trimester is possible, and they need to take a call on whether to continue with the pregnancy or not. Thank you.
Thank you, Sushmita. Just a comment on how do you differentiate primary congenital aphakia from sclerocornea, because sclerocornea is something we see quite frequently, and most of the time we're not able to see into the eye at all. So do we perform imaging for all these patients to make sure that they don't have any other?
Yes. Ma'am, somehow the thing that I showed, this silvery hue of the cornea along with the sclerocornea somehow is very pathognomic. I mean, now that we see it, the shiny hue of this cornea is pretty much characteristic of the condition. And yes, we do UBM in all of them. And if we don't see the lens, that sort of clinches the diagnosis.
Can I just add a point, Dr. Shanta?
Sure.
Yeah, so let's say some centers don't have a UVM. Even doing an ultrasound, regular B-scan ultrasound is something we routinely do for these children. So that also can pick up if there is an absence of lens there. So that is something that we need to remember. And with Sushmita, if you these children from sclerocornea, the way you differentiate, most often sclerocornea corneas are very small. They are really microcorneas. And even these children with primary congenital aphakia can also present with microcorneas. But typically what I feel clinically when you differentiate is extremely thin cornea, pearly or silvery kind of a appearance. And they have a prolate kind of a shape. That means the limbus or the blood vessels, very tiny blood vessels, the conjunctivization or whatever you want to call it, is more seen in the superior limbus and in the inferior limbus, not so much at the temporal and nasal limbus. So the corneas are actually like this. They are prolate kind of a cornea. And typically every eye appears like that. And when you do a indirect ophthalmoscopy to see the fundus, you can very clearly see the fundus, which is in contrast to the, so if you see so much of a corneal opacity, we feel that we may not be able to see the posterior segment, but they have such good red glow, and we'll be able to very easily examine the posterior segment. That's when you realize the discs are healthy, things are fine. They should be able to move around and work. And some of our children, whom we have this primary congenital aphakia, in fact, they don't even have nystagmus. They walk around as if nothing happens, and they are seeing like any other child. So they are able to have good ambulatory vision. Some of them even go to school, but then when you look at their eyes, they appear really white. Apart, the sclerocorneas have more of this conjunctivalization, and I don't know, maybe the way the blood vessels of the cornea, people should be able to tell us, or Dr. Khan may be able to tell us the difference in the phenotype between these two typically. But the sclerocorneas don't have the silvery kind of an appearance in the central cornea. What Murali tells me is it is because of the reflection of the light that happens on the surface of this cornea that they appear whitish, but actually they are not.
Okay. Any other comments?
Because even on the corneas don't appear edematous. They appear quite all right. Yeah, that's a good point.
So we had a child with primary congenital aphakia with megalocornea. The corneal diameter was 18 millimeters at birth. And this child also had infantile diabetes. So it was a real challenge to manage. We performed only cyclophotocoagulation, and the child is comfortable, has no potential vision, but systemically is doing very badly. So that was a surprising finding. That was the only patient with infantile diabetes mellitus that I have seen with refractory congenital glaucoma.
I have a question for Dr. Khan. So apart from FOXE3, is there any other mutation that is associated with this particular condition?
I don't know of any other gene mutation that causes primary aphakia. FOXE3 mutation can cause other phenotypes also. It doesn't always cause primary aphakia, but when you have primary aphakia, it's 99% it's FOXC3 mutation. And as I had mentioned while Dr. Shmita was in a limbo, the mutations in the gene can be dominant or recessive. So it's interesting to look at the parents. It just depends on the nature of the mutation, but most of them are recessive. And as I also just mentioned previously, and as she mentioned in her conclusion, or towards the end of her conclusion, that this is specifically expressed in the lens, and it's specifically a lens developmental protein. But because the eye requires a normal lens for normal function, when there's no lens there, everything else becomes abnormal. The vitreous, the cornea becomes discolored. And again, that's because the normal lens induces the other structures of the eye to become normal. And when it's not there, you get this cascade of abnormality throughout the eye.
Thank you, sir. Do we have time for any more questions? Because there's one question regarding medical treatment, because many of these glaucomas are really refractory in nature, and a lot of them have a corneal compromise. What are the medications which are safe to tide over until surgery is done, or when multiple surgeries have been done, what do we use? Is dorzolamide a contraindication or a relative contraindication? What is your opinion? Any of the panelists?
Well, there are theoretical contraindications, but practically we use almost everything except for brominidine in very young children. But I don't have any hesitation other than brominidine in very young children. I don't have any hesitation in any of the medications. I mean, there are theoretical issues with the dorzolamide, carbonic anhydrase, and things like that. But practically speaking, if the child is otherwise healthy, I don't have a problem.
Anybody else has any take on medical treatment apart from the usual contraindications? The use of.
I agree with Dr. Khan. Here, primarily, it is not even otherwise, it's not an endothelial problem, so we don't have to really worry about it. A hazy cornea doesn't mean that they cannot take the dorzolamide. So even in the children with, let's say, post-keratoplasty eyes also, the carbonic anhydrase inhibitors are not something that the cornea surgeons ask us to stop. I mean, if you have a choice, you give beta blockers, but otherwise the second line is anyway carbonic anhydrase inhibitors, and then we move on in that way, and brimonidine is definitely contraindicated.
So thank you, everybody. I think we have completed 1 hour of the webinar, so I'm not sure whether we can continue with the questions. Can the organizers give us a...
I think Pratibha said we can go on as much as we want. I think if there are questions, we could take them on.
There aren't any other questions except for one on penetrating keratoplasty. I think we made it very clear that penetrating keratoplasty in primary aphakia is contraindicated, but what about in primary congenital glaucoma itself? What are the results? How well do those children do? In those with persisting corneal opacity after surgery, if they require penetrating keratoplasty, how well, what are the results?
So at least in our, I've seen that children with glaucoma do particularly well with penetrating keratoplasty, possibly because it's an added insult to the pressures in an already compromised outflow. But children who have clear corneas do actually very well with an optical iridectomy. And I started going down that path more than pushing them for penetrating keratoplasty, because a good optical iridectomy with a peripheral clear cornea, the children, even with glasses, do much better than the repeated visits. And it's a very, very labor intensive thing having a pediatric keratoplasty done, and with them rubbing and children playing, I'm not so sure. So I'm very, very conservative unless it's a totally opaque cornea. If I see clear cornea, usually in infantile glaucomas, the corneal opacity which remains is in the center, usually the periphery clears. So if I have clear cornea, I would go in for an optical iridectomy. I'd like the consensus.
I'll just add a couple of points, Dr. Shanta. So I agree with Sushmita that as much as possible, their own corneas are so much better, even if it means let's say intranasal area of the cornea is quite clear, do an optical iridectomy and they should be able to do well. A couple of points that I thought I should mention is that I have one child especially, in fact, which is completely documented, where we thought this was the central edema, or rather a central scar. So it completely healed in the periphery, only a central scar, and the intraocular pressures were in the range of 18 to 20. And the cornea was not clearing, and the parents were very insistent that the other eye has become completely normal. This eye, please do something. I don't want that white opacity kind. And I was not keen on sending them to the pediatric cornea specialist. I said, see, otherwise the eye is okay. Why should you worry? But the pressure started going up in the next couple of months, and ultimately I gave in and did a tube for that child. That means this child was previously had a trab and trab and a DLCP. But this is the third surgery in that child. And to my surprise, exactly 1 month after the tube surgery was done, even that central scar, which I thought had scarred, actually was edema. Completely cleared. Completely cleared, and the cornea is not something that you can actually recognize. And I couldn't recognize the cornea because it had so much of a central opacity. So most often, before sending them to a pediatric cornea specialist, take care of the glaucoma first. So once we fix that, I think relatively things are okay. And despite that, if they have an opacity and they need to operate, I think the cornea surgeons, at least in LVP, they do a tremendous job. In fact, they are at it all the time. Until all the sutures are out, they are following them up very, very closely, almost on a weekly basis. They put them on immunosuppressives right from day one, and along with the tacrolimus. Some of them also are asked to get influenza vaccine, because every time the child has a common cold, they come back with a suture infiltrate. The suture infiltrates are the biggest problems, and secondary ulcers, and hence an endo for a tricycle eye is a major problem in these eyes. If that can be taken off, once all the sutures are out, the rest of them are, I think, doing very well. Murali has a huge series. In fact, I think that must be ready now for submission, or maybe he's already submitted a large series where PK in eyes with primary congenital glaucoma. And they have pretty good success rates. Dr. Mandal must be knowing many years of patients being operated. But I agree that if we do not have a choice, meaning like there's so much of opacity that we definitely need to take care, amblyogenic time is something that you cannot waste, then I think we need to send them, otherwise not.
There is an interesting question for Dr. Sushmita. In primary IPGS, if there is a problem with the ciliary processes and they are hypoplastic, why is the intraocular pressure elevated?
Because the outflow, so it's a very, very a critical balance between outflow and inflow. I agree the inflow must be less, but then with no trabecular formation, obviously if the pressures are high and the discs are getting cupped, and like Sirisha said, you can see the posterior segment. So you don't want to leave it untreated also. Its DLCP is limited only if the pressures are high and we need to treat it. But there are a couple of children where the pressures are not high and there's no glaucoma, but they just assume to have congenital glaucoma because they're a small baby and the corneas are white. So I think because of that critical thing, just one quadrant of, reducing aqueous and that's it. But incisional surgery is really bad. And just one comment about this lens. I wanted to ask Dr. Khan, how far after postnatal birth really do the trabecular structures and anterior segment structures develop? Because there must be a reason as to why lens pairing vitrectomies have lesser glaucomas, cataracts done after 6 months of age have lesser glaucomas. So there must be something in taking out the lens very early in life as well. So is there a genetic answer as to how long does the anterior segment take? I know the books say about 6 months, but practically what should we take as a cutoff of taking out the lens very early?
Well, this is a dilemma that 20 years ago, we were taking out the lens in the first week of life. But now we know that we can get similar visual outcomes without the same horrible risk of glaucoma if we wait until about 6 to 8 weeks. It's a balance. I would love to wait longer. It seems like the incidence of glaucoma goes way down if you wait until about 10 months or later, but you can't do that in a congenital cataract. So for the congenital cataracts, we have to balance. We have to wait until about 6 to 8 weeks because we know waiting that long, we don't lose from the amblyopia perspective and we decrease the risk the aphakic glaucoma, but the risk is still there. The risk is still much higher than if we waited until 10 months, but we can't wait until 10 months. So we wait until 6 or 8 weeks to take out the cataract. And, you know, they still have the risk for glaucoma. Why is that? That's the million-dollar question, you know. There are a lot of theories about that, why that's the reason. Is it physical, just because the iris diaphragm goes back? Is it because there's some kind of substance that's coming from the vitreous into the anterior chamber, because we're doing a posterior vitrectomy also, we're doing a posterior capsulotomy also. Is it from inflammation, from retained lens capsule fibers, because we can't remove the whole lens? Nobody knows the answer, but the observation is there. And so right now, you know, we wait until 6 to 8 weeks for the congenital, and if we can avoid cataract surgery, we do. I just want to mention one other point about the corneal opacity, and you know, it's a great point Dr. Shirisha mentioned about putting in the tube and the opacity cleared. Some of these patients with congenital glaucoma from CYP1B1 mutations have an intrinsic corneal abnormality, and they actually have an intrinsic corneal opacity that has nothing to do with intraocular pressure. That's not most of the cases, but some of them do. So some of them are going to have corneal opacity even if the pressure is well controlled.
Thank you. I think that's the last question from the audience. So thank you for fantastic cases which were presented and a really good discussion. Thank you all for taking time off on a Sunday to participate in this meeting, and I thank the organizers for having given us this opportunity to share our experience with who was attended. Thank you.
Thank you.
Thank you.
Thank you very much.
Thanks.
Thank you. Bye. Thank you, Dr. Khan. Bye.
Thanks so much. It's nice to see everyone.
Yeah.
Nice to see.
Have a good day. Bye-bye.
Good.
I actually have to go to clinic. It's a working day in the UAE.
Okay. So that's really nice of you to attend then.
Okay,
Thank you.
bye-bye.
Bye-bye.
Bye.
Thanks.